Today we're going to talk about an evidence-based practice for young children with autism called JASPER. You probably don't know what JASPER is. It stands for Joint Attention, Symbolic Play, Engagement, and Regulation. This is an intervention that's really focused on engagement. So the main points are that engagement should be an intervention target. And so we'll talk a little bit this morning about what the active ingredients of engagement are. And then we'll talk about how do you intervene on engagement, some important considerations, and then some example studies that have established the research base for thinking about engagement as an intervention target. And so let's think about what this means. So what are the early signs of children with autism? So the main problem is this engagement with other people, right? And that's pretty consistent across the age span. So with little kids, it looks a little different than it looks like with adolescents, but it becomes a problem all through the lifespan. There are some behavioral signs of engagement. So early on, it might be shared attention and affect. Joint attention. Do you know what joint attention is? Okay, we're going to talk about that in detail. So if you don't know, you will know, hopefully by the end of the lecture. It's about social play with others. So we want children to learn how to play, but they also need to learn to play with others. So social play is the distinction in terms of play. And then conversation as kids get older. So let's think about some of the early signs of engagement and non-engagement. So I'm going to show you some video clips. The first one is the ADOS-T, which is a diagnostic assessment for young children with autism. And this is one of the example items. So you'll see a little boy who's 17 months old who's being assessed for autism. And you'll see that he's got an object in his hand. So just think about how he's trying to engage with that object and with the person. Let's see.
Yeah.
So you can see how focused he is on the object, right? The object seems a lot more interesting than that person. And that's pretty unusual for a little kid. So here's a typically developing 17-month-old in an assessment called the Early Social Communication Scales, which we'll learn about in a little bit, actually developed by Peter Mundy, who used to be here in Miami for a number of years. Let's see.
Charlie! It's a cow! Monkey! Oh, parrot?
So what a big difference, right? So he's using a lot of different skills. You know, he's got shared affect, he's pointing to direct attention, he's following attention, he's really engaged. So big difference between those children. You can see in one case a lot of engagement, in the other case not so much. So the reason why these kinds of skills are so important for children with autism is really on a basis of a lot of experimental studies. So in the 1980s, there were a lot of experimental studies where people took matched samples of children with autism to children with developmental delays, not autism, and typically developing children matched on either language age or developmental age. And what they found was that autism was specifically deficient for showing joint attention. And it was specific to joint attention, not requesting. So there's a difference between these two kinds of pre-linguistic behaviors that develop within the same period of time. So children might request something, right? We know the difference between requesting and joint attention, yeah. So requesting is to point to something in the cupboard, for example, to say, you know, I want that, but without using words. So a child is pretty emphatic about that, might not have a lot of positive affect because they're really dead set on getting those cookies. Whereas if the child is doing the same behavior, pointing, but they're trying to direct your attention to something interesting like the airplane in the sky. They might look to the airplane, look back at you, look to the airplane, and share positive affect. So positive affect is a marker of shared attention, joint attention. And that's the piece that is more deficient in young children with autism. It's actually a marker that we look for in terms of even early diagnosis. So the requesting is easier, right? So when we're teaching children, you know, we teach children to request, it's much easier than teaching them to either follow joint attention or specifically to initiate joint attention. Another sort of the research basis of joint attention is that when you just look at joint attention as a skill in these mixed samples of children, the deficiency in joint attention alone can classify about 90% of the kids with autism. So it's a pretty powerful predictor of autism. And more importantly, joint attention skill predicts to language outcome. So it predicts both at the same time that you assess the child and then years later. So in Marion Sigmund's lab at UCLA, they've followed children for up to 16 years, and joint attention still predicted their language at age, or 16 years later. So that's pretty important. Joint attention is also a predictor for other children, neurotypical children, children with developmental delays. So it's a really important pre-linguistic skill. Let's see, the title's not coming out. Okay, it should say the difference between skills and states. So there's some confusion in the literature about what people are targeting. So sometimes they're targeting joint attention, but what they're really referring to, well, they might be referring to requesting and not joint attention as how we've defined it in the autism literature, which is much more proto-declaratives as opposed to proto-imperatives. Proto-imperatives being requesting, proto-declaratives being joint attention, sharing attention. So sometimes people are really focused on the skills of joint attention, and other times they're talking about the state of joint attention, the engagement piece. So in studies, it's a little bit confusing, but in both areas, children with autism are deficient. So in the specific skills, for example, pointing to share attention, showing a toy to a parent, they're doing less well than children matched for language age or developmental age. But they're also different in terms of their states of engagement. So in the first little video clip that you saw a little boy who was very object focused. So his sort of level of engagement was focused much younger and kind of stuck on the object. So typical children get really interested in objects too. Or they're really interested in face-to-face interactions especially with their parent. But they quickly learn to shift between those two. And once children learn to shift between the two, after about 6 months of development, so it's really early on, then they're able to engage in more of these gestures like pointing to share or pointing to request. Okay, so those develop anywhere between like 6 and 18 months. You should see those flourishing. But our kids with autism kind of get stuck, and so then we talk about them being in this sort of object-engaged state. So they're really interested, they're very focused on the object, but shifting their attention is tough. We also know that from neurotypical literature, being in what's called a supported joint engagement state is the important one for the development of language. So yes, we want children to have an object and to look between the object and us, and that would be coordinated joint engagement. So if you're playing with something and the child is, looking at what you're doing together and then looking at you and smiling and talking, that's coordinated joint engagement. And that's that's where you're trying to, that's what you want to get to. But between about between about 18 and 36 months, children spend a lot more time in supported joint engagement. The child is playing with objects and the person, but the person is kind of scaffolding most of the interaction. So the child's not spending a lot of time looking up at the parent, but yet they know that the parent is there engaged with them. It's a fine distinction. But I think a lot of times in autism, we're demanding the child look at us a lot, and that's tough for them. It's tough to shift their attention, and what happens if you do that a lot is that you lose the engagement piece. So it's hard to sort of do it all. So this supported joint engagement doesn't require the child to look at you all of the time, but to just kind of be there with you in this support joint. And we'll kind of model this through over the course of the next couple of days so you see. So we were really interested in doing targeted interventions. So thinking about how could we target the core deficits that we were seeing in young children with autism. So to really affect engagement, the intervention needs to be very much targeted on engagement. It needs to be very dense. So it needs to happen like every day, every waking moment if you could. And it needs to be long term because this is not an easy fix kind of intervention. The targets of intervention do change with development and with the amount of impairment in children. So with young children, we think of them as being fairly pre-verbal and that their development is going to be fairly rapid for the most part. So our developmental targets stay focused on joint attention and engagement, but they change as the child gets a little bit older. We might focus more on joint attention language once they are gesturing and really starting to talk. As children get older, we may still focus on these very young targets if they're still nonverbal, all right? But if they're very verbal and highly functioning in the general ed classroom, we might focus much more on the peer relationships than we would on a therapist-child relationship. So to understand what we're affecting, so what is changing in engagement, you need to really think carefully about the outcome measures of intervention. So they need to be meaningful. And this has been a really difficult issue for most researchers in autism. What is the outcome of early intervention? Most of our comprehensive interventions, so meaning that they're very intensive, oftentimes 20 to 40 hours a week, they cover all areas of development, very comprehensive. Those outcomes have really focused on IQ or DQ for young children. And you know, cognitive impairment is not the core deficit of children with autism. There are certainly lots of cognitive issues, but increasing IQ is not the main outcome measure. An important one, but not the core deficit, I guess I would say. So you can still have a very high IQ and be very socially impaired, and we certainly see that with older children. So again, we need to think about, well, what should the outcome be and what is meaningful in terms of these targeted interventions. So I'm going to talk a little bit about a study that we did starting in about 1997, so a long time ago now. It was a comparative efficacy study where we really focused on core deficits in young children with autism. So the core deficits for us were these gestures, so pointing to share, showing a toy, and also symbolic play. So we know that children have difficulty more with the imaginative, symbolic aspects of play than they do with the functional, how to use an object, although you will also see some delays in functional play. So we really wanted to focus on those particular core deficits. And so we did a couple of studies. The first one was children from an early intervention program. They were all in the same hospital-based early intervention program. There were 58 children between 3 and 4 years of age. So this was in the late 90s, and we were seeing children at 3. Now we see children much younger, but then 3 was pretty young. And then so we did this initial study, we did a follow-up a year later, and then we did a follow-up 5 years later. So I'll talk about those studies. So all children were receiving 30 hours of ABA a week, which is really intense even back then. But it was short-term because it was a hospital stay. So, I mean, it was an outpatient treatment program. So 30 hours a week for 5 to 6 weeks. We used therapists to actually conduct the intervention. The children were randomized as they came out and consented to participate. They were randomized to either just stay in the ABA program, getting their one-on-one interventions, or to get one-on-one on joint attention or one-on-one on play. All right, so they got the treatment every day for 30 minutes for 5 to 6 weeks. And the approach that we used was combining a developmental approach with good strategies from ABA. And it sounds a lot like PRT, but it's not exactly, but it's within that genre. It sounds a lot like floor time, and it's not, but it's in that genre. It really is a combined method, and it's very targeted. And so what we'll talk to you about is what are the slight differences between this approach and the process that we want you to understand compared to maybe some other more adult-led but with a child focus, or just child focus, no adult leading, so either way. So in this study that we did and sort of where we've evolved in this treatment was that where we taught the children the joint attention intervention, we got an effect in 6 weeks on some joint attention skills. And the skills that were tested both with mother-child interaction. So the moms were not, or moms or dads, were not part of the treatment protocol. So this was kind of a far generalization of the treatment. Or it was independent assessments on the ESCS. So in 2 ways, we looked at the children's change in joint attention. So it wasn't in the therapy sessions that we were measuring the change. And what we got was that the joint attention group improved in joint attention after 6 weeks, but so did the play group. Not quite as much, but they both improved, and the control group didn't change very much at all in the 6 weeks, so that would be time 1 to time 2. And then at 6 months and 12 months, we reassess the children, and we find that at 12 months, both of those experimental groups, kids who got the play intervention, kids who got the joint attention intervention, both changed in joint attention initiations. So that's key. It's the child spontaneously initiating, not being prompted, and not just responding, okay? With the play group, we had very similar findings. So if we measured play level, so we start where the child is and we increase their developmental level in play, we found that the play group improved over that 6 weeks. So did the joint attention group. Not as much. And then when we come back 12 months later, the play group is pulling away from both other groups and significantly different from both groups, although the joint attention group also improved in symbolic play, right? So, I mean, what do you surmise we get from this kind of a study, right? We get what we teach, right? So if we teach this content, we get a change in what the child can do on independent assessments or with their parent. So that's pretty important. And as I said, this was in the late 90s, and now you can see how it's evolved today. So lots of ABA programs now bring in joint attention content and play content because the content matters. It's a developmental target that's important. But for us, why are we doing this? If we're going to change this behavior in children, we want to know that it's affecting some larger core deficit. So children with autism often come to our attention because they're language delayed. So we tested their language skills at each time point. And we find that in the follow-up a year later, both the joint attention and the symbolic play groups are significantly different from the control group at the 12-month follow-up. So it translates to about 15 to 17 months change in language development at the 12-month follow-up, compared to about 7.5 months for the control group. So that's pretty remarkable, right? So these children were getting 30 hours a week for a short period of time. They left that early intervention outpatient program and they go off into the community, and the least amount of hours that any child got was 20 hours a week, ranging to 46 hours a week of ABA. So the question would be, well, is it something about the background interventions that are affecting these language outcomes? And we don't think so, because the control group in this case was getting the most number of hours after they left the group, or after they left the intervention program. So if anything, they were getting more hours of treatment and should have done better. But on the other hand, maybe they weren't doing as well, and parents knew that they needed to get more hours. So, you know, it's hard to tease that apart, but it doesn't seem that it's the number of hours that were affecting these changes. So now what happens when you think about the heterogeneity in the autism syndrome? So in this program, we did not exclude children if they were functioning below, let's say, an IQ of 35 or below 12 months developmental age, which is very common in research studies. We just basically took any child who was willing to participate as long as they didn't have co-occurring medical conditions that were serious. And so some of the children came in with fewer than 5 words. So these are 3- and 4-year-olds who are just not very verbal at all. And when we separate out the groups in that way, we just look at the low language groups, we find that in this case, the joint attention intervention really matters. So the children with low language who got the joint attention intervention made 13 months language gain over 12 months, compared to the control group that made 3 months change. So again, if you think about this developmentally, children who have the least amount of language probably need this pre-linguistic type of intervention even more than children who have more language skills. Okay, so does approach matter? So when I started this study, I had no way of knowing whether a particular approach was more effective than not effective. And this is something we talk about in the field a lot. Should we be doing ABA? Of course, everyone's doing ABA, but how much should it be shifted towards a developmental approach versus a much more behavioral approach? So in this study, we decided we would do both, right? It was combined developmental behavioral on the floor, so it wasn't exactly floor time, but it was closer. And then we also did 5 or 7 minutes of discrete trials at the table, all right? And that was really just to sort of prime the child to know this is the skill we're working on, and then we would go to the floor and we would have many more opportunities for the child to engage in lots of different activities and lots of different toys. And that was their generalization. All right. So do children learn joint attention or play skills faster using one approach or the other? And so we had very strict criteria for mastery. We focused, for example, on play. We focused on diversity of play and not just the frequency. So we weren't interested in a child feeding the doll, feeding the doll, feeding the doll, but that they could feed the doll, brush the doll's hair. You know, they had some diversity in their play. So more than, that's called a type in our coding scheme, more than one type of an unprompted initiation. So pretty strict. We weren't interested in prompted play or prompted joint attention. And they had to do that for 2 consecutive days. And so what I'm gonna show you are the days to performance mastery, so the number of days to reach that. And one of the other issues here is that we always did the discrete trial first and the play on the floor second. So it's not a truly randomized test of these 2 different approaches, so that's a weakness. So when we look at the results of table versus floor, and table being discrete trial and floor being more naturalistic, is that generally children reach performance mastery in the discrete trial setting first before the naturalistic floor. But it's, 4 days versus 6 days or sessions. So not a big difference. When we look at it by skill, we see that a little bit of a separation here. So in the symbolic play intervention, the children learned it faster at the table than they learned it on the floor. But with the joint attention skills, they learned it about the same. All right? So still both a little better in the discrete trial, but not significantly different for joint attention, but yes for play. So I think it's kind of interesting to think about, but again, the targets were very developmental. And so now we're going to talk about, I'll talk about some of the literature and why that sort of developmental targeting is so important. So the goal that we selected for each child was developmentally individualized. And the goals were selected from 3 assessments, and 2 of those we're going to show you during this workshop. The structured play assessment, so we understand where the child is in terms of their developmental abilities in play, what their play level is. That's really important because that's the context that you're going to create for this intervention. And then we also want to know how, what the frequency of their play is and the types, whether they have much diversity in their play. And those are the quality aspects of play. The early social communication scales is also important for figuring out if this child is responding or initiating joint attention or requesting or even just social interaction. So again, another independent assessment. And then we always want to watch the child play with their mom or dad because they're familiar to them. We want to see what the play looks like. And then we also would play with the therapist as well, just to see what we can get. The selection of the target is based on emerging skills from these assessments. So you want to target a skill that looks like it's just emerging in a developmental sequence. And if it's not emerging, if you don't see any emerging skills, but you see a very solid mastered skill, you would go up 1, but then go down if you're not having success, and we'll show you how to do that. And we followed a typical sequence of skills. So how skills come in for typical children. Now that's a little bit of a question because in some other research we've done, we find that children with autism actually have a slightly different sequence. And the question I think as researchers is, do you target the skill that comes in the typical developmental sequence, or do you target the skill that just seems to be the next one that should appear for this child because they have autism? And I think you're okay going either way, but in this study we've pretty much followed a typical model. So now let's talk about why studies on joint attention, and now there have been many, are not all the same. So there are many more than this. I think there are probably closer to 20 about now, most of them single subject designs. So, it's hard work to do. So single subject designs work because they're usually 3 to 5 children. But I've selected 4 just to be representative. So in the first one, I think what's interesting here in this multiple baseline design using DTT and PRT, a naturalistic ABA model, is that to initiate mastery for initiating joint attention took many sessions. So you saw in the previous study that about 6 sessions for that individual goal. And now we have 157 sessions. So again, measurement is different, likely different, and targeting something developmentally that's emerging and perhaps approach. It could be any of those things that affects this difference. But that's a lot of sessions. And sometimes if you're doing the same thing over and over again on this kind of a developmental skill that you're trying to engage a child and be motivating, it may take you longer because it gets boring. So in this study, this is a randomized controlled trial of a particular therapy. So PECS, which is very directive, right, and it's a communication approach, and really facilitating requesting more than initiating joint attention, I think, versus RPMT, which is much more focused on joint attention. You don't get a difference in those two groups in this randomized controlled trial, but what's interesting is the moderator effect. So if you came into the intervention and you had more initiating joint attention, you progress much faster. Okay, so that makes sense. But now to go back and think about, well, what happens if you have no joint attention? So that's what we want to affect change on. You expect that a child who comes in with more skills is going to have a faster rate of change, but what you want to do is to make sure that you've got a pretty consistent slope increase for those children who come in with no joint attention. In this study, there's a set order in how you teach, and that's actually pretty true of most of the very behaviorally oriented single subject designs. All children start with the same sequence. So in this case, it's, you're going to play face-to-face, then you're going to do turn taking, and then it's responding to joint attention, and then it's initiating joint attention. And while that makes sense developmentally that that's the way it should happen, these skills actually overlap and come in oftentimes together. And so in this case, you have one child who showed no change in RJA or IJA. So to me, that's a concern. And again, I would think that a more flexible modular approach is probably more effective. At least this is what I think we learned from these studies. And in this study, there was just weaker generalization and maintenance. And that's often common when we try to teach a skill that's so developmental in a very discrete trial method, right? We're changing a behavior, but if the behavior doesn't have developmental meaning, it's not going to maintain, and it's not going to generalize to other people or to other contexts. So I think we need to be careful about that. So for me, these 4 studies represent some issues that we need to think about when we do intervention on joint attention and play, and when we do research studies. So I don't think we can underestimate the importance of development, that joint attention and play skills are uniquely developmental. So if you teach at a point in the child's development where they're ready to learn, then the skills should appear in a fairly brief period of time, not very many sessions, because you've broken it down using good behavioral thinking about breaking these skills down. And then once mastered, it shouldn't go away, right? It should maintain, and it should generalize to other partners given the opportunity, right? So there's also a payoff long-term from this early focus on joint attention, joint engagement. So the follow-up of children from that original study 5 years later, we saw 40 out of 58 children. 32 of those children were highly verbal at age 8 to 9, and 8 were, so about 20% were still minimally verbal. And that's pretty reflective of what we get out of intensive early intervention. So when we think about the children that were in this early intervention program and predicting to their expressive language at age 8, we looked at a number of different predictors. So the treatment group that they were in, their chronological age, their initiating joint attention that they came in with, their play level that they came in with, expressive language, their developmental quotient, and their gender. And what we find, what predicts their language at age 8, still the treatment group, pretty amazing. So both treatment groups, not differentiating between the joint attention and the play treatment. If they were younger in chronological age, and the level of initiating joint attention, their play level, and their expressive language. So again, important targets for early intervention. So what did we learn from that set of studies? that the active ingredient to early intervention is a focus on these early developing core deficits, joint attention and play. Have I convinced you yet? Maybe. Results, though, suggest that the mechanism is likely engagement, right? Because the joint attention and the symbolic play interventions led to a similar outcome. So what's the common active ingredient between those two interventions? Probably engagement. But the approach also matters. So this fusion of developmental and behavioral approaches is really important. So what is the evidence for that approach, right? We get somewhat better maintenance and generalization with a developmental behavioral approach than we do with just a strictly ABA discrete trial approach on these targets. It generalizes to caregivers. It maintains, it predicts both proximal and distal outcomes. And we find stronger findings than we find in other studies. So I think it's really important to think about where the child is developmentally and then targeting those skills one by one. So from those early studies, we now have this evolved intervention model that we call JASPER, for lack of a better term for it. And we've extended it to several other studies. So we've now done parent-mediated interventions where it's not the therapist so much working with the child, but teaching the parent. So we've done one study that's published with toddlers. So these were 2 to 3-year-olds with their parent. We used a randomized controlled wait list design because we wanted all families to get intervention. So that's another issue with all of these early interventions, is the ethical issues about not providing intervention to families that are really desperate for intervention. So in this case, we did a short-term wait list, 8 weeks. We thought parents could wait that long, and we could then test the effects of the intervention. Since that study, we've also just finished a comparative efficacy study where we've looked at the parent-mediated, active, hands-on kind of intervention versus just parent education, giving parents the information, and to see if our results are similar or different. And we've also just finished, but haven't analyzed the data yet, of in-home interventions for underserved, underrepresented families and preschoolers. We've also done extensions to school-based populations, so we've trained teachers, paraprofessionals to do this, and I'll show you a little bit of data, again a pilot study, and another one with nonverbal children, so children about 12 months developmental age but preschool age in the schools, and trying to see if we can bump up their engagement in language and joint attention. Okay, so an example from parent-mediated study. So we, in this case, thought about what we were doing as therapists and created 10 modules, which you'll learn about today. And we taught the parents one module at a time, but like the children, we wanted to individualize, because parents come in with a particular skill set as well. And so we individualized based on the interactions that we observed with the parent and the child. So prior to the intervention. Then we conducted 3 sessions per week for 8 weeks with a 1-year follow-up. The sessions were anywhere from probably 40 minutes to 40 to 50 minutes. And we really focus now on joint engagement states and play to teach joint attention. So again, fusing those 2 initial interventions together. And what we found was a decrease in object engagement. So if you think about the little boy I showed you in the first clip, very object engaged. So the goal for him is to be less object engaged, right? So the top line is the control group that just doesn't change in that 8-week period of time. And the experimental group is on the bottom, and they're decreasing in object engagement. And then they continue to decrease on the follow-up. We don't have the top line because they got treatment, and so that's what you lose in this waitlist design. And when we talk about increasing joint engagement, it's largely supported joint engagement, although there's some coordinated joint in this graph, but you see that that really increases for the experimental group, whereas again, the control group just stays fairly flat. So it suggests that we can change this, but it needs direct intervention. In this particular study, functional play types increased and they maintained growth over time. But symbolic play didn't change. So why do you think that is? They're not mic'd. So it changed. It didn't change because these children were so developmentally delayed, right, that symbolic play may not be the right target for most of them. So for some children, they were ready for symbolic play and they actually increased in that. But as a group, most of the children were really at the functional play level. Responding to joint attention also increased and maintained over time. We were much less successful with initiating joint attention again, probably due to the young age and also the short-term treatment, possibly. But so initiating joint attention is very difficult to change. And we also had caregiver factors that were associated with the outcome. So for those of you who work with families, you know that they're not all the same, right? They buy into different interventions more or less. And so that mattered. So how much a parent bought into the treatment, believed in the treatment, improved the outcome for the children. So at the beginning, there wasn't really a difference in their expectations for treatment, but the quality of their involvement over time did predict whether the children were more engaged, joint engaged or less. The other extension was with a teacher-mediated pilot study. So again, we taught modules similar to the parent-mediated model. We taught the paraprofessional teacher one-on-one to work with a child that they selected in the class. We had a blinded observer go to the classroom and then watch what the teacher and the child was doing. And again, short-term, 6 weeks, 2 sessions per week. What do we find? Teachers increased the use of the strategies that we taught them. So there were 11 strategies, and they taught on average about 7.5 of those strategies just in this free play observation. And children actually started to initiate joint attention more in the classroom, which is great. So while I thought that that was very exciting and thought that that was a great generalization, in fact, it's probably not a generalization because we taught them in the class. So within that context, you saw the behaviors of both teacher and child. And I think that that's important to remember too. So wherever it is we want to affect the change is likely where we should do intervention. But there is a difference also in terms of children who you might intervene with. And there's a difference between pre-verbal and non-verbal children. So many of the young children we see are pre-verbal. We can get them to talk, right? We know that about 80%, at least based on our best estimates right now, are going to be verbal, at least of the children that are in intervention studies. Now, the children in intervention studies are often a selected group of kids. So we oftentimes, not we, but lots of researchers will exclude children who are too low in their language abilities, or for example, under 12 months developmental age. So that may be an overestimate of the number of children who are becoming verbal, at least from research studies. Because the other estimates are about 30 to 40% of children are minimally verbal, even into school aged. So somewhere in that range, we have children that just aren't progressing as fast as other children. All right. But it's important because we know that the best social and adaptive outcomes for kids are children who are verbal, meaning using spoken language, by school aged. Right? So it's a huge focus in early intervention to get kids talking. So it's also interesting that there are a number of children who remain minimally verbal who've had access to early intervention, right? But they just haven't gained the requisite pre-linguistic skills. So again, it suggests that we really need to focus not only on language in preschool, but on these pre-linguistic skills that develop before language to, increase the numbers of kids who are verbal as they go to school. So we also have a study where we're combining Jasper with a very specific language intervention called Enhanced Milieu Training, which is by Ann Kaiser at Vanderbilt. So it's very nice in that it parallels what we do with objects and play and engagement with children. It parallels with the language. So they're very much focused on the same targets, but not so much on the context. And so blended, it makes for a fairly perfect intervention for some of these children who are minimally verbal. So I'm going to show you a video for fun. A little boy who's 5.5 years old with autism. He came into intervention with no functional words or even sounds, so he wasn't making a lot of sounds, although he's clicking for yes and no. He's clearly a very smart little guy, but he's just not using language. So you will see session 1, which is basically the first therapy session. Sometimes kids are making progress already in the first therapy session. And you can see that using this blended approach, the therapist is going to give him a choice item, which is a very common in EMT. It's called a milieu episode because he's not talking. And then you'll see him halfway through the intervention, session 24. This is a 6-month intervention, twice a week. So you'll see him at month 3 and you'll see him at 6 month. For this little guy, he also has a Dynavox to help him with augmenting the speech. All right.
Want boat or blocks? Boat on.
Boat.
Green. Sorry?
Colors.
No green.
Colors. Blue.
Oh, you want a blue back.
Boats. Drive.
Drive boats. Blue. Girl.
Girl. Boy.
Boy. Turn.
Turn. Shovel.
Oh, shovel dirt.
Shovel.
Swing.
Thermometer. Hit.
Hit thermometer.
So, a few things. You can see her mirroring and mapping his language. She's talking less, so he talks more. So we tend to overpower children with talk when they're fairly minimally verbal. And so there's a lot of different techniques that she's using to try to get more initiations from him. And you can see that the ideas come from him. She's programmed the Dynavox with all the possibilities. But this child also, by session 5 or so, could program the Dynavox. Clearly a very smart little guy that really needed access to communication, and we tend not to give children enough access to communication. So for him, he came in at session 1 with pretty much no words. 20 words functionally used was our criteria for even coming into the study, and you can see by midway he's already above that, and by the time he left he had nearly 60 unique words that he was approximating. His articulation's not very clear. Now, we've seen him since then, and he's doing, many more words. He actually left the session with 300 approximated words. So again, access to communication and talking less and using a context for teaching him matters. So he's made nice progress. So not all children who are minimally verbal look just like this little guy, right? They're all quite variable. And so a lot of times you have a lot of behavioral issues, right? Because a child is trying to communicate, they can't get their needs met, and so you have a lot of behavioral issues. So now I'll show you a little guy who's 7 years old. He had a few words. They were mostly scripted, which is something that is very common, but he was not able to go to school because of really, really terrible behavior. So you'll see the first session, we just have 2 people trying to stay in contact with him. And I don't show you a long clip because it's fairly loud. And then you'll see how he progresses also over the course. Whoops. I don't want to do that, but that's where he improved to.
Beep. Sit down.
You want to bang him so he can sit?
Stand.
Slide. Slide.
Off. Slide down. Let's slide down. Let's slide down roller coaster.
Okay, so similar in that he also made a lot of progress, but we needed to regulate him first. So the first couple weeks were a lot about regulation. Also separating the father from him. So by month 3, the father was out of the room. But a lot of change for this little guy, just in terms of play even. So you could see in the beginning, he doesn't even play with toys appropriately. And so that's very common of these children. So you can see, even though they've had lots and lots of hours of early intervention, if we haven't targeted play and joint attention and all of those skills, they come in at 5 to 7 and they still don't have those skills. But you can make fairly rapid progress by going back again to those targets if need be. It's still an appropriate intervention. At some point it gets to be not an appropriate intervention. So you would change how you play and what the expectations are, and you're not playing with children who are 12, unless they're so intellectually impaired that maybe then it would still be okay. But I do think that one has to think developmentally about the child as well. Okay, I think that ends the research portion, and what we want to talk about now are very specifically the assessments that are really important for knowing what to target. And I'm not sure if you have questions that you want to ask about what I've talked about now, first, before we move on.
I'm assuming assuming you're going to talk about, as a speech therapist watching this, it's very hard to see that as the therapist you don't say anything, because we've always been taught to just talk, and to get the child to talk. So I'm assuming that you're going to talk more about that intervention type method of letting the child talk first. So I won't ask the question now, I'm assuming you'll get to it.
We'll
But
talk.
I just want I guess the theory behind it, and I see, from a sense of letting it be much more child directed, of having that child say first, then use scaffolding or mapping, whatever it is.
Right.
But as a therapist, as a speech therapist, you're saying, well, if they don't know the words, then you need to give them the words first. So I guess that's my question, my overall question.
So, I think that's a really excellent question. We don't want to overpower them with talk, because they learn not to talk, and they also, if we ask a lot of questions, they respond. And it's great, especially parents want to know what they know. So if you ask the question and they answer the question, you know what they know, but then you don't see them initiate that conversation. So this sort of approach with the not talking very much and the mirroring and the mapping and all of that is based on EMT. And while we had some aspects of that in our Jasper approach, we got our language completely cleaned up by the group at Vanderbilt who do EMT. They said we talked too much, and we didn't think we talked that much. So we weren't narrating for the children, for example. Because you want to give children input, and you want to get output. So people do that in different ways, right? You can give a lot of input, and we give a lot of input, both verbally and non-verbally. We don't demand a lot of output. However, in this approach, you get to a point where you would say to the child, say block, right? So there is a sequence of prompts that we would go to. But you can see that the child's initiating, and so it works, and it's based on a really strong evidence base on the language piece in EMT. So.
Yeah, and that's the great thing about seeing that, is that by not actually talking and letting them just initiate, and then that it's spontaneous rather than prompted, which for a speech therapist is, for anybody is what you want.
Yeah.
So I think it's great. It's eye-opening. It's really eye-opening.
And it's hard. Mm-hmm. It's really hard, because it's hard for us to not talk, and it's hard to watch it because it's not a lot of talking going on. But it really does work. And the children we have examples of children coordinating us. So the other big piece of this that you'll learn about is developing the play routines. That it is about the context of play that you develop, and sort of developing this little kernel of a routine, and then kind of expanding it out all the time so that it doesn't become repetitive and fixed, but is always kind of evolving. And the children actually, because you're using so much of what the child's interested in and what the child is doing, that you really can expand both their play, their language, and their joint attention all at the same time. And it's hard. So while the adult doesn't look like they're doing very much, they're actually working really hard. And you'll feel that.
So we'll just be talking a little bit about how to administer some of these assessments that Connie mentioned in her lecture. We'll be modeling and practicing these assessments all day, so we'll just do a really quick introduction. So prior to intervention, we will always conduct the structured play assessment and the early social communication scales in order to determine treatment targets for each of our children. This way the intervention can be really individualized, which is really beneficial for child outcomes. The structured play assessment will be used to assess the child's play level, and the ESCS can tell us more about the child's current joint attention and behavior regulation skills. So first, briefly to go over the structured play assessment, if you turn to page 9 in your manual, you can go over it with me. That might be helpful. So basically, this assessment takes about 15 to 20 minutes to administer, and it will allow us to observe the child's highest level of spontaneous play. There are 5 sets of toys, which are outlined in the slide. The first set is the combination set of toys. So that includes a shape sorter, a puzzle, and nesting cups. Set 2 is the tea set with dolls and some tea materials. Set 3 is the grooming set with the same dolls, a phone, a brush, and a mirror. Set 4 is the sleeping set with some smaller dolls and furniture, and set 5 is the barn set with a barn, a dump truck, some blocks, and animals. So in order to administer the structured play assessment, we want to have the child sitting at the table across from us, and then we present each set of toys in the order shown on the slide. We have some general guidelines that you can look over as to how to present each set of toys. Just briefly, I'll go over a few suggestions that we have. So for set 1, we want to make sure that all of the puzzle pieces are taken out of the puzzle so that the child can have the opportunity to put them in if he or she can. For set 2 and 3, we want to make sure that the dolls are in front of the child, seated upright, so that the child can see them in case they want to do some practice with the dolls. For set 4, we want to make sure that all the furniture is upright, again, to give the child a better opportunity to do play acts with those. Set 5, we want to have the barn to the side of the child so that both the assessor and the videographer can see the play acts that the child is doing in the barn. So the biggest thing for the structured play assessment is not to prompt for a specific play level. We really want to see what the child can do spontaneously. So instead of prompting, we can merely comment on what the child is doing. So if the child is putting a piece in the puzzle, we can comment cow. If the child's putting the cow piece in, something similar to that. There are also no set rules as to how long each set should be on the table. It really depends on factors such as whether the child has, played with any of the toys and the child's play level. So if we think that the toy sets may be much too easy for the child, then we can move on quickly because the child will get bored. If we think that it's too difficult for the child, then again, we would probably move on quickly because the child may not know what to do. Another thing to keep in mind is that we want to minimize the time that the child's sitting there with no toys in front of them. So before cleaning up the first set of toys, we want to immediately bring over the next set and have that ready before we remove the first set. And I guess finally, it's also important to present the toys in the order on the slide. We know it's not always possible with our kids, so you can switch the order if it's necessary for the child, but we can try to keep this order if possible.
All right, so I'm going to be talking about administration of the early social communication skill. So again, like Amy said, it's another assessment that we do prior to starting intervention, just to know what our targets are in terms of joint attention and behavioral regulation, which basically means requesting skills. So if you refer to your manual on page 7, you'll see a list of toys that we usually put on a table next to the interventionist who's administering this assessment. And we put all the toys out so the kids can see what options they have and actually request for the toys that they're interested in. So the first couple toys are the wind-up mechanical toys, and there's 3 of them, and also the bunny, which we activate. So when you're presenting these toys, you want to put it on the table in the corner of the table out of reach of the child, because we want to see if the child wants a toy, whether they'll reach for it or if they'll expressly request for it. So for each of these toys, you want to present it 3 times. So you activate it, and you wait a little bit after it's been activated and see if the child will look at the toy or whether he'll request for a toy. And if he does, great, you can present the toy to him. But if he doesn't, you can go ahead and give the toy to him as well. And then, so you do that 3 times. And for the hat, ball, and car, sunglasses, and comb, they're basically toys to see whether the child will socially interact with you. So for these toys, you want to put it in the middle of the table where he can actually grab the toy and put it on his head if it's the hat, or put it on his eyes if the glasses, and see if after he does that, he'll put the glasses on you. So kind of a social interaction going on. If not, you want to kind of prompt for it and say, can I have a turn? And if the child gives you the glasses, great. If not, you would actually put the glasses on yourself and see, and prompt after that and say, can I have a turn? And see if the child will give it to you again. And for the book, you want to see if the child would actually respond to your social joint attention. So if the child says he wants the book, you can go ahead and present it to him, and you actually call his name out when you are turning the pages and showing the pictures that Jack, Jack, and you're pointing at a picture in the book, and see if the child will actually turn towards the picture that you're pointing at. But you want to make sure when you're presenting the book that you don't touch the pages, because you can see that is a clear point that they're responding to. And for the plastic jar task, again, you want to make sure that it's presented at the, put in the middle of the table so that they can reach for it. And the main thing about the jar is it should be tightly screwed on, so you're kind of prompting for the help. So if you see that they're having trouble, you can prompt them, say, do you need help? If they're not asking for help on their own. And lastly, for picture on the wall, basically to see if they're responding to your joint attention. So you'll see in the room later on that there's 4 pictures on the wall, and you'll start from your left side and say, Jack, Jack, and you kind of wait and see if they respond. And then for the next picture, so from the far left to the middle left, and then the far right. So Jack, 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 and you'll present 4 pictures to see if they'll respond to your joint attention. And then we have the walk mouse and creep mouse song. So basically that's another social interaction. And the way you would sing the song is, it's basically a tickling song. So you go, walk mouse, creep mouse, walk mouse, creep mouse. And we're trying to see if the child will look at you and get excited, and if they will request for more tickling. And you do that twice. So walk mouse, creep mouse, walk mouse, creep mouse. And that's 1 set, and you can do it later on for your second set of songs to get them initiated. And then we also have the balloons, and that's usually one of the fun toys that the kids like to request. You'll blow up the balloon 3 times. So you blow it up, and then you deflate it, and you can make a squeaky noise and see if they'll request for it, and you could put it in the middle of the table. And usually our kids are really young, so we're gonna have a difficulty blowing up the balloons. So they would give it to you to request, or they could just say, help please, something like that, and then you can blow it up again, and you can do it up to 4 times. And lastly, I wanted to say that a lot of times our kids are really young. So like Connie said, there's toddlers coming in that's 2-year-old, 3-year-old, so you're gonna have parents in the room sitting with them. And a lot of times the parent would like to help them. And it's okay if the kids turn to their parents to request for help, but you wanna make sure that because this assessment, we're trying to measure what the child can do independently, that you tell the parents exactly that you wanna see, what skills they can do. And if the child requests for help from the parent, just let the parent know that you can acknowledge it, but have them direct it back to the interventionist. So there's not too much prompting from the parents.